Hello, can you hear me? All right. We have 1 hour to discuss this topic. I'm Dr. Jones Chen from the Division of Clinical Pharmacology. This year, I'm going to talk about this topic on behalf of Dr. Christopher Lum, who has delivered this topic all along. The topic today is prescription and medication management in older people. Well, this is the overall overview of the topic. So first of all, we would want to avoid the adverse drug reaction in older adults, and then we will discuss the various the contributing factors causing an adverse drug reaction and try to tackle all these one by one. And then we will select the suitable drug for the best interest of the patients. And then there are some conceptual framework of prescription medicine in older people. So we want to go through these steps one by one. What is iatrogenesis? It's still a geriatric giants. We know that the geriatric giants include the 4I traditionally. This is one like the intellectual impairments, which is cognitive impairment, dementia, delirium. The other one would be the instability, such as the orthostatic hypotension, and then immobility, risk of falls, and incontinence. And then we add another one, which is iatrogenesis, and it actually can mimic all of the above problems. So patients may present with falls, present with postural hypotension, dizziness, delirium, and urinary incontinence because of the medications. So iatrogenesis means an inadvertent effect of complications resulting from medication treatment or advice. And we know that the adverse drug events are quite common in elderly, all right? So in fact, they are the major drug user in the populations. And about 1/3 and then 2/3 of the community dwelling older adults and also the nursing home residents respectively experienced drug adverse reaction in the past, and some of them required hospitalization. Overall, the adverse drug reaction leading to hospitalization and healthcare utilization and resources use is tremendous. All right, and then many of them may experience major events and also causing death. So the medication-related problem is the 5th cause of death, and account for about 50,000 to 75,000 older people die each year in the United States. So we have performed some drug survey in the ward, in the acute medical ward, concerning the older people who were admitted to the hospital, presumably because of the adverse drug reaction. So some of the adverse drug reactions are easily picked up, like gastrointestinal bleeding, electrical disturbances, hypoglycemia, and precipitation or aggravation of the heart failure and fluid overload. It accounts for the majority of the adverse drug reaction that we discovered throughout the period of the surveillance. It was done in 2009. So as you can expect, the medications causing these kind of adverse drug reactions are the NSAID, aspirin, diuretics, antihypertensive drugs, including thiazide that may cause electrical disturbances, and anticoagulants and oral hypoglycemic agents, including insulin as well. Many of these adverse drug reactions were predictable and avoidable. So this slide was from Dr. Lum. So the major concern, as listed in the previous slide, is some acute medical problem that can be easily picked up through maybe the diagnosis, maybe some laboratory abnormalities. But however, as listed in the previous slides, the geriatric giants that probably is not covered, maybe not really well recognized by the frontline doctors. So these patients present with false intellectual decline or delirium, confusion, and functional decline, and also because of the use of the majority of the time was the CNS drugs or psychotropic drugs. And there are some actually, this phenomenon was recognized by previous researchers. So some produced the so-called drug burden index. You can easily search this index in the internet. It is a calculator, all right? Is calculating the cumulative effect of the anticholinergic drug as well as the benzodiazepine, okay, causing the effect in the CNS and also subsequent the adverse reaction leading to functional decline in the elderly. So this is as you can see that the anticholinergic and benzodiazepine, they act each in a synergistic effect and causing adverse reactions, and this is in a cumulative relationship. And not the causes or precipitating factor leading to adverse reaction in elderly is quite complex. As I wrote this chapter for the curriculum in geriatric medicine years ago, as there are some aging causing multiple comorbidities and organ dysfunction, and then it will lead to problem and also decline in the or maybe sometimes it's age-related, sometimes it's disease-related, causing pharmacodynamic changes and also pharmacokinetic changes, and also some homeostasis function decline. And then patients would have some other psychosocial problem in the coping of the disease, and also some social problem leading to medication problem in adherence, medication error as such. So overall, these could lead to adverse reaction, and sometimes the doctor did not recognize the adverse reaction, and then they tend to overprescribe and add another drug to treat and this kind of new developed adverse reaction, and then this is so-called the prescribing cascade. So sometimes we will recognize the medications are inappropriate, that I will later give you more detail about. So what is the definition of inappropriate medications? So you can see overall this is quite complex. So we go through the age-related changes. First, this is the age-related change in the pharmacokinetics. We'll go through the system like the ADEM, the absorption first. Overall, there's some changes in the physiological changes in the gastrointestinal tract, such as there's a decline in the gastric acid secretion, leading to increase in the gastric pH, decline or delay in the gastric emptying, altered GI mobility, and also decrease in the intestinal blood flow. But overall, the gut is so long, and the medications overall, the absorption would not be affected, and as well as the therapeutic response. But however, there would be delay in the peak concentration and the time of the concentration Tmax and the Cmax. But overall, the area under curve, the curve will be expected maybe longer and flatter. But overall, the total area of under the area under the curve would be quite similar to the normal one. So we would not expect the therapeutic outcome would be quite different from the normal one compared with the age or older people. And the other one would be the distribution. As you can see from the advertisement, the distilled water advertisement. So people, when getting older, the water content, the water compartment in the body will be smaller, but then the fat compartment would be increased. So maybe we have muscle loss, we have bone loss, but we have fat increase in the body. So this will lead to some distribution in the drug event. The overall, the definition of the volume of distribution is the apparent volume in which the drug is dissolved when we check the overall the blood concentration of the drug, and then it will represent this apparent volume in the body. So this is not a real volume, but a theoretical volume of the drug that is dissolved in the body. If it is comparable to the systemic circulation, that is the blood volume, maybe about 6 liters, 7 liters, we would think that the drug mainly is confined to the blood or water compartment. But then if the volume is really, really big, maybe more than 50 liters, so we would think that the drug is probably dissolving into the body fat. So what is the implication to our decision in prescription? That is, we know that if the volume distribution, it mainly affects the loading dose of the medication or the time to start onset of the response. So in patients like elderly people, they have lower body water, and then we would try to load the digoxin with a smaller one, loading dose, compared with the normal individual adult. If you want to give a patient a dose of Valium or diazepam to control the confusion or insomnia or agitation, so you would expect the drug to take onset of the action will be slower, because majority of the dose of the diazepam will be dissolving to the total body fat instead of some or maybe little of the diazepam will be diffusing to the CNS through the blood-brain barrier. So it just dilutes the effect of the diazepam because of the total body fat increased. And so you will expect the effect of the diazepam will be slower compared to that with adults. So the next one would be the metabolism. Overall, the metabolism of the drug is only minimally affected, right? Although we have some changes in the aging-related pharmacokinetics, like a decrease in the enzyme of the phase 1 enzyme, but mainly the phase 2 enzyme would be relatively preserved, and we have decrease in the liver mass, decrease in the liver blood flow, but overall the metabolism, because of the abundant liver enzyme available, the metabolism would not be affected unless in the situation of disease. For example, the patients have cirrhosis. So overall, we do not expect the metabolism is affected, or we need to have some dose titration or reduction because of the normal aging decline in liver problem, liver condition. But when the patient has cirrhosis, it is the other story. But overall, we do not have unlike the kidney function, we do not have a good calculator or estimation of the liver function to see how to reduce the dose. It may be affected if some drug like the verapamil, propranolol, which has high liver extraction ratio. In this case, the liver is very capable to metabolize the drug, be it a protein bind or protein free, free drug. The main limitation factor is the liver blood flow. Okay, in case if the patient has heart failure or decline in the liver blood flow, and then it will lead to the decreased distribution or presentation of the drug to the liver for metabolism. In that case, you would want to reduce the dose of propranolol or verapamil as such. The other one would be the elimination. Okay, this is the main process that is affected by aging. All right, so in aging, we will have a decrease in renal blood flow, decrease in glomerular filtration rate, and decrease in the tubular secretion. So overall, it would affect the maintenance doses of the drug mainly, okay, by which the drug is mainly eliminated by the kidneys. For example, digoxin, atenolol, lithium, morphine, vancomycin. So you would want to estimate the renal function in the older adults, and it is largely predictable. Okay, the age-related decline in the GFR is about 1 milliliter milliliter per minute per year. All right. So by the time the patient is 80 years old, you can see that the glomerular filtration rate is only about 60, maybe, okay, milliliter per minute. And then you can see that when the patient has 60 glomerular filtration rate, it is almost to the extent of the stage 3A CKD. All right. So when we need to have the medication dosage titration or adjustment renally, that depends on the drug is renally excreted or not. All right. If the drug is renally excreted, by the time the patient has 3A, we need to start to consider the dosage titration. But then if the drug is non-renally excreted, we can postpone it not until when the patients had the 3A or 4 stage 4 3A or 3B or 4 renal impairment. So the lesson to learn is very important. This is the only thing to consider in the age-related decline in the pharmacokinetics is the renal function. We probably need to consider to estimate the patient's renal function before we prescribe. And by the time the patient is 80 years old, the patient is approaching to the 3A stage CKD. So we will probably want to reduce or titrate the drug to the renally adjusted dosage for some medications of interest. So how to estimate the creatinine, the renal function? The renal function, the serum, creatinine and urea is not a good estimation, all right? Because of the change in the body mass. As you can see that even a elderly with 80 years old with normal serum creatinine concentration or level, and that means the patient already has the GFR 60. But why the patient has normal creatinine level? It's because the patient also has decline in the muscle mass or muscle equilibrium, creatinine equilibrium. So that's why the patients can maintain a normal creatinine serum level. But then if the patient has already developed elevation in the creatinine serum level, and then it's already suggesting that the patient has more than 50% of renal function decline by the time the patient is 80 years old. So this is the usual formula we would want to adopt or maybe to estimate the renal function of the creatinine clearance or the eGFR. The gold standard is the cockroach gauge. That is a CG formula. In particularly, if you want to use the formula to estimate to titrate the medication to the really adjusted dose. But the disadvantage is we need to measure the patient's body mass, body weight, all right? In contrast to other formula, which is more convenient, like the MDRD and also the CKD-EPI. Currently, in our hospital, we are using the CKD-EPI as such. And so it's said to be more accurate than the MDRD. In particular, it can give rise to the creatinine clearance or eGFR with more than 60 milliliter per minute. And the MDRD, if the patient has the eGFR larger than the 60, it just cannot give you a good estimate on that. And then looks that the CKD EPI have not been fully validated in Chinese children less than 18, elderly, pregnancy, and patients with serious comorbidities or extreme body size, body mass, or nutritional state. And then the second one would be the age-related pharmacodynamic change. So what is the pharmacodynamic? That is after the absorption, distribution, metabolism, and elimination, the drug will end up going into the cell, all right, and then exert this pharmacotherapeutic response. So largely, it is a post-receptor response, and there are some change in the body homeostasis, in particular elderly, in which they could have a decrease in the capacity to alter the pharmacotherapeutic response or physiological response to the drug. So, for example, patients may develop significant partial hypotension because of the use of the diuretics or ACEI. So we would want to, the implication is to want to start low of the dosage and then go slow. If you want to titrate, you would want to go slow. So this is a mnemonic in the geriatrics pharmacology. We would want to start low and go slow. There would not have significant change for the enalapril or prazosin. And for the beta blocker, because of the aging, we would the patients would be expect to have lower beta adrenal receptor response. So in case of using the beta blocker, we would need to at the end increase the dose compared with the normal adults. There will be higher increased sensitivity to the drug of like the diuretics. So you need to monitor closely the blood pressure and electrolytes in the elderly. For warfarin, it will have more, the patients would be more sensitive to the dose of warfarin. So we would want to start low and go slow. The maintenance dose of the warfarin in the elderly would usually be lower than that of a normal adult. Benzodiazepine neurotropics, so these may make patients more susceptible to all the CNS side effects such as delirium, falls, instability, and also extrapyramidal side effects to the neuroleptics. So we want to try to use the lowest dose and also the shortest duration to achieve the therapeutic response and then stop it. They are having more problem with the renal function and renal blood flow. So we would want to use the NSAID COX-2 inhibitor with caution, all right? More susceptible to the side effect of the morphine as well. The other one we need to pay attention is the prescribing cascade, okay? As I introduced shortly, prescribing cascade is when one use another drug to treat the first drug adverse reaction. It's actually the doctor did not or do not recognize the adverse drug reaction is the new symptoms, is the adverse reaction actually because of the use of the drug on the first hand, all right? So the example would be like patient was given antipsychotic and developed some kind of extrapyramidal side effect, mask face, corporeal rigidity and falls, and then misdiagnosed as Parkinson's disease, and then the patient was given levodopa for treatment as such. And then perhaps the levodopa may also lead to partial hypotension, and then the other problem would be falls. So it is it is not a good manner. We would want to, for example, recognize the AE and then stop the drug if it is possible. Other example like diuretics, increase in the dehydration, and also hyperuricemia causing gouty attack, and then the patient was given colchicine or maybe steroid or allopurinol to treat the gout. To recognize this and reduce the medication cascade, and always consider the possibility of ADR as the drug newly added. All right. And polypharmacy is very, very common and then increasingly common nowadays. As you know that many clinical trials are suggesting the medication is beneficial to the patients, increase the survival, reduce some other the progression of the disease, etc. And then you will be expecting that when once the population aging, the disease accumulating, in the disease loading, in the burden in one individual will be increasing, and then the patient has multiple comorbidities, and then with each comorbidity is treated with several drugs. For example, in COPD, patients was given short-acting beta agonist, long-acting ICS, LABA, LAMA, this kind of medications. And then for one patient with COPD, they have been already given 4 to 5 different types of inhalers. So, and then the patient has some other problem, diabetes, hypertension, ischemic heart disease. This is expected. The patient has polypharmacy. So we do not blame polypharmacy nowadays, but we would want to avoid inappropriate polypharmacy. So the definition of polypharmacy is really, really difficult. And then there are multiple and various definitions. In those days, we define more than 5 drugs is defined as polypharmacy. But I don't think it is important right now. Maybe 99% of the patients has polypharmacy. If I'm talking about the hospitalized patients, right? There may be some patients in good health in the community, never end up into the hospital, and then they probably do not need any one of the medications. But in our hospital, in the hospital setting, patients are very common to have polypharmacy. So what are important is we want to avoid inappropriate polypharmacy. That is, the medications without indication or maybe causing harm to the patients and unnecessary, and this is defined as inappropriate. So, what is more important is not only the number of medications, but we would want to see that if there's any appropriate indication for the medications to be prescribed to the patients. So one of the index would be the so-called medication appropriateness index. You would want to apply this index and calculate the mark, the score for each of the medications the patient is receiving. So this is time consuming, although it would give you a very accurate results, but it is mainly used in the research setting. Just go through the so-called what is the definition of the medication appropriateness. So does the drug has any indications? Is it effective for the conditions the patient is taking the medication? Correct dose, direction, practical direction to the patients, any drug-drug interaction, disease interaction, any duplication of the effects, any acceptable duration. For example, if the patient is putting on the proton pump inhibitor because of the GU or DU, and the patient has no previous history of gastrointestinal bleeding, is not a high risk, is not taking any long-term aspirins or maybe NSAID, perhaps we would want to just give the patient's proton pump inhibitor as long as the patient has the peptic ulcer healed. All right. So we would want to just stop the the proton pump inhibitor maybe 3 months after the initial presentation to the hospital. So, and then finally would be the course. Another tool, this is so-called explicit scoring. That means we would want to. Sorry, this is the so-called implicit. All right, implicit scoring. That is, the doctor has to use their own judgment in order to determine that the drug is appropriate or not. And there are some other tools such as the Bayes criteria and the later one would be the start and stop criteria. This is the so-called explicit criteria. That is, there are some well-listed criteria, and then the doctor or maybe the healthcare professionals just go through the list and then go through the patient's drug list and then patient's profile and then determine whether the drug is inappropriate or not. So the first one would be the Bayes criteria. The latest update would be 2019 edition. So I just go through the little bit of the definition. There's some table listing the drug. For example, these drugs are considered high risk and should not be used in any of the elderly, all right, with or without disease. For example, try to avoid the anti-arrhythmic drugs 1A, 1C, or 3 as the first line to treat dysrhythmia. Try to avoid the use of the PPI for duration longer than 8 weeks. Try to avoid the use of the Z drug for insomnia. So these are considered universal to any of the elderly. And then there are some conditions and the patients with certain disease or disorder. And then these conditions are considered the factors if the patient requires some medications, and then these may be considered inappropriate. For example, patients with dementia, we would try to avoid the Z drug, antipsychotic, and patients with fall or fracture, try to avoid opioid if possible, etc. Okay, certain condition and drug pairs. And there are some situations like patients may be associated with higher risk than the usual one. Okay, patients with aspirin for the age of more than 80, dabigatran if the creatinine clearance is less than 30 SSRI, and in the patients with hyponatremia. So this is the, again, drug and condition pairs. Some other table 5 shows you the potential important non-anti-infective drug-drug interaction. I'm not going to detail about that, but there are some situations like the use of the anti-infective medications to avoid, like, for example, patients with dabigatran and the creatinine clearance less than 30. So these are not really elderly specific, but in general, patients with these conditions, you would want to reduce or avoid the drug if the patient has a renal function problem. So the other criteria would be the so-called the stop and start, all right? Screening tool of older adults with potentially inappropriate medication. Again, it is a explicit criteria. So it listing 80 criteria in the stop and 34 criteria in the start. So this so-called inappropriate medication screening tool is becoming more user-friendly and also more important nowadays, in contrast to the Bayes criteria. So the beauty of the Bayes criteria is easily applicable, all right? You can actually put this criteria, because this is explicit, and the drug name is actually very important, and then you can use some computer-assisted program to try to screen the patient's medications profile and drug list together with this profile, or just like a filter, all right? If the patient has the highlighted drug of a potential inappropriate medications list of the Bayes list, and then you're using some computer programming, all right? You can easily highlight the PIM, okay, in the patients with the Bayes criteria. But the start and stop, you usually need to have some judgment as well. For example, this is the start and stop on CNS drugs. So I list some criteria here. For example, if patient try to stop the tricyclic antidepressant for patients with dementia, glaucoma, cardiac conductive abnormalities, constipation, etc. All right, try to stop the Z drug, the sobriquinone, sobriderm, and also the benzodiazepine. if the drug is used for more than 1 month, right? Etc. This you still need to have some judgment in the use of the start and start. And start means try not to omit important drug. So if the person is quite old, but don't omit the use of very important drug in the elderly simply because of the old age. For example, we would want to use anticoagulation, be it warfarin or direct oral anticoagulant in the case of chronic atrial fibrillation. But of course, you would want to balance the risk of bleeding, such as the use of the HA has black score. And then you need to treat the high blood pressure with antihypertensive drugs. Of course, you would want to consider if the patient has any risk of falls, etc. So lastly, we would want to go through some list of medications which is so-called the high-risk medications. All right, as you can see here, the risk of developing adverse drug events in older adults is cumulative. If the increasing age, we have increasing odds ratio. Increasing comorbidities, we have increasing odds ratio. Increasing the number of drugs prescribed, we can also have increasing odds ratio as well to develop ADR. And some certain drug, all right, is also having higher risk to develop adverse drug reaction. So these drugs I highlight here is as shown in the very beginning of the lecture. These drugs are not uncommonly used. They are quite common. And actually common things come first. The use of the warfarin or maybe even the direct oral anticoagulants, NSAID, aspirin, oral hypoglycemic agent, insulin, diuretics, calcium channel blocker, nitrate, the anti-seizure, antipsychotic, and sedatives. So these mainly cover the cardiovascular and also the CNS drugs. These are the main drugs causing problems. Another group of drugs causing problem is drugs with anticholinergic. Okay, so I just list some of the drugs here. As you may not know, actually some drugs can contain anticholinergic effects. For example, older generation H2 blocker, cimetidine, ranitidine, etc. And of course, the antidepressant, in particular, the tricyclic antidepressant and some quadriceptic antidepressants, such as dophapine or doxepin, these can lead to anticholinergic effects. Some antispasmodic, of course, treatment for overactive bladder. So these drugs must be anticholinergic. All right. So this is try to have some concept about the drug. Of course, there are some calculator. All right. You can go through this website and then try to input some of the name of the medication, and then it can calculate the total score of the anticholinergic burden score, right? So if the score, if you type a patient is taking, for example, Abilify, which is the psychiatric drug, the score of 1, and then type the patient is taking another drug, which is called carbamazepine, score of 2, another drug, dophapine, doxepin, class of 3, and then the patient already has, because of these 3 drugs, the patient has the score of 6. And then with the score more than 3, it is already defined as very having problem. This is a high score, and the patient is having high risk of developing anticholinergic related problems such as delirium, dementia. So this medication discrepancy in older adult is very common. Okay, and because of the multiple problem, multiple comorbidities, psychosocial problem, multiple prescriber, frequent hospital admission, and frequent change of the dosage and regimen. So it will lead to use of the medication with problem, and it is not uncommon. The frequency, dosage, omitting some of the important drugs is very common. So I can tell you some example, which is really I recently encountered. And then the non-adherence is basically can classify into intentional and unintentional. All right, intentional. Don't think the patient is dumb. Okay, they are quite smart. They know that the drug is after taking the drugs they experience side effects, so they smartly stop the drug. And then not until when you talk to the patient, and then they can tell you. They have a lack of the understanding and why they need to use this drug. Is there any risk or complication or side effect of the drug? So you need to explain why the patient is taking the drug. There may be some financial problem, in particular the use of the new anticoagulant. I can guarantee that some of the patients, like if they are using the money to buy the new anticoagulant, you must ask, are you taking the drug once or twice daily? Because they think that, oh, I need to, buy the drug, for example, apixaban, okay? It has to be taken twice daily. And then they omit one time in order to save money. So you must ask them. This is a very common phenomenon that I experienced. The patients is taking, try to save their money, pocket money. Unintentional, of course, there are some conditions that may lead to inadvertent non-adherence to the medication. So the implication is try to reduce polypharmacy, reduce the regimen, simplify it. Maybe you would want to use once daily if this is possible, and try to cut down the tablets. The patient doesn't have good hand dexterity to cut, and probably also has poor eye vision to handle the small pills, and then they can get loss of the medications drop on the floor, all right? And then you need to discuss, and just like you are asking a informed consent, tell the patients why, any risk with the treatment. And then, of course, if it is a kind of an inhaler, you would want to check the inhaler technique as well. So this is I recently experienced. In fact, this patient is my mother-in-law, right? She has asthma. And recently, because of the weather change, become dry and cold, and she had the asthmatic attack. She has been using, the PRN Ventolin. But then because of the bronchospasm, she told me that she had wheeze and shortness of breath and decrease in exercise tolerance. So I increase the medications, add another, the ICS, another LABA, etc. At one time I tried to add the LAMA as well. Okay, this is the LABA, Ombris, all right? I try to add this Ombris, which is a dry powder capsule. And then she told me that she could not use this because she put this capsule into this space, and then you have to press these two buttons in order to cross the capsule. And then she said, oh, this capsule cannot be crushed. She don't know why. And then she stopped using this. Okay, I try to use another one, which is another option, the Frutiform, the LABA, another LABA with, this is the LABA LAMA, LABA and ICS combination. And then she use it well, but then she still has wheezing. So I add the aero chamber in order to help her to try to increase the drug delivery to her lung. And then she's still asking why I follow your instruction. That your medication doesn't work, and my asthma is increasing severe. So I visit her at home. She lives in Zhangguanou, and then I drive all the way to Zhangguanou because I heard that she was very in critical conditions to the state that she may need to require hospitalization. And I go to her home and check. Oh, and then I asked her to demonstrate the inhaler technique to me. She put on the Ventolin, put on the Frutiform, and press one button and breathe one time, just one time. And then she said, you told me that to press one button and one time without the aero chamber. I doing the same thing. Press one time, breathe one mouth. But in fact, if you are using the aero chamber, you will want to press one time and breathe for maybe 10 times in order to inhale all the medication stored in the spacer, right? And then so that's why you would not expect any, unexpected error the patient is taking. Another story is recently encountered patients. Is a very dangerous situation. 80 years old. The medications list is not very complex. Just atrial fibrillation and heart failure diagnosed in 2018 with a beta blocker, apixaban, furosemide, and losartan. Really, really clean and simple. But then recently in June this year, after maybe 2 or 3 years of waiting for the echocardiogram, it showed that, her atrial fibrillation is most likely due to valvular heart problem instead of non-valvular heart problem. It has the thickened mitral valve and then causing mitral stenosis. The underlying cause is likely due to chronic rheumatoid heart disease. So in that case, we cannot give apixaban. We have to switch it to warfarin, right? So in November, the medication was changed to warfarin. And then the doctor and the nurse phoned the patients. We prescribed the warfarin dose with a bit of loading and then followed by the maintenance of 2 milligram and then check the INR again. And then basically days later, the INR was 4 after loading and maintenance with 2. And then again, we phone call the patients to reduce the warfarin to 1.5 milligram. And then we provide another time opportunity for checking the INR and follow up. So by the time I saw the patients, maybe last week, and then we reviewed that her INR was, it's quite good. Okay, you maintain with 1.5 milligram. And then your INR was 2.9, really, really good. And then I saw the patient on 7th. She told me that, doctor, I'm sick with the medication last time you given me. So I stopped it just 3 days later. So I asked her, what kind of medication you stop? She said, I stopped the carfentanil. Okay. Really, really sick. I switched back to bisoprolol. But then, are you taking the warfarin? Yes, I'm taking it. 1.5. I'm following your instruction. But have you stopped the apixaban? No, I still keeping it. So the patient is taking the warfarin and the DOAC simultaneously. Of course, the INR is just normal, but I think she may have increased risk of bleeding. So if the story teaches me that you need to have a communication quite well with the older people. They do not understand the medication instruction label, listed in the label. Mainly the name of the drug is listed as English, and then some of the patients have poor English literacy. So overall, how we can manage the medications with the patients, we identify some high-risk medication, identify the problem of polypharmacy, inappropriate medications, recent hospitalization leading to change of the medication regimen, etc. Identify any poor social, psychosocial situations that susceptible make the patients more likely to have poor adherence and also adverse drug reaction. And then we provide some medication review by, for example, ask the patients to bring back the medication using the more traditional way is the brown bag, okay, 嗰啲紙袋. All right, some This is brown bag, and then the patients put all the medications to the bag and bring back to the clinic for your advice. We do the medication reconciliation, check any potential inappropriate medications, high risk drug interaction, and support the patient. So we have some so-called conceptual concepts. You would not follow this concept one by one in a very busy clinical setting, but just give you a brief of the concept. And I believe that not many of you would end up to become a geriatrician or a medical doctor. Some of you may become a surgeon. Some of you may become a psychiatrist, or maybe pathologist, radiologist. And then you would not care the medication list. So, but as an intern, all right, I can see that many of the interns will just copy and paste, and then for each time the patients comes into the hospital, adding new drugs, didn't delete or omit the previous drug, and then the medication list accumulate to 30, 40, etc., including some topical skin, eye, ointment, this kind of things. So the problem is becoming more complex. And as an intern, as a general physician, we would want to simplify the patient's list. All right. So first of all, we would want to ascertain all the drugs, be it a hospitally prescribed drug, over-the-counter drug, herbs, supplement, etc. Right. And then we would want to identify the patients who is having high risk of ADR. So this is one of the tools, okay, used in the research setting in Italy is so-called the Geronto-Net ADR risk score. And you would pay attention to the simple list like here, more comorbidities, heart failure, liver disease, number of drugs the patient is taking, previous ADR, and renal impairment. So these are the maybe more important risk factor that make the patient susceptible to ADR. And then we would want to estimate the life expectancy. Oh, how? I can tell you later. And then we would, because of the patient's premorbid function, comorbidities, and expected life expectancy, we would want to design whether the overall treatment goal for the patients, like prolonging the survival if the patient having good health, prevent major comorbidities, improve the function or relieve symptoms if the patient is really, really frail and sick. And then the patients probably would have a short life expectancy. So this is the way we estimate the life expectancy from the so-called life table data. So this table shows you the life expectancy in the United States. If the patient is now 70 with a so-called 50 percentile of the health, this is the upper percentile, good health, normal health, or maybe this is poor health. So end up if you see a patient in the hospital, most likely they are in the poor health situation, or maybe some of them would be in a normal one if they have only occasionally comes into the hospital. So you will expect a 70-year-old man, he still have 14 years to go, all right? Maybe 8.4 if he's really sick. And then for patients of 96, 95, only 2.2. So the same apply to the female. Do we have similar data in Hong Kong? Yes, we have. We have the Hong Kong life table, but the data is not robust, not as robust as here. We only have the life expectancy of each age, but we do not have the upper and the lower 25th of the percentile. So I'm asking the statistic, the census, okay, department to see if we can provide the upper and the lower 25th percentile data. So the fifth step would be try to ascertain the indications of the medication list, okay, and define the goal. All right. If the patient has heart failure, and then the patient is taking ACEI, beta blocker, these are for improve the survival. If the patient has Diuretics, this is only for symptoms, right? If the patient has nitrate, this is only for symptoms. It doesn't affect or alter the survival. So you would want to classify the medications in accordance to the indication. So we also want to estimate, all right, if some of the medication is for prevention, like calcium carbonate for prevention or treatment of the osteoporosis. How long does these medications to take effect in order to prevent one death in these patients? Or maybe the patient is taking bisphosphonate for osteoporosis, statin for prevention of atherosclerosis. For how long these medications need to take effect? If the patient has general life expectancy of less than 5 years, so we continue to put on this medication. So this is a time for you to judge, right? So this is the table showing you some kind of preventive measures in order the time to benefit. As you can see here, the literature showing that majority of the time for the statin for primary prevention of the atherosclerosis or any cardiovascular event, it takes 2 to 5 years. If the patient has life expectancy less than 2 to 5 years, you probably consider that this medication is less relevant to the patients. If the patient has polypharmacy, multiple comorbidities, and medication use, you would consider to omit or stop this medication. The same apply to some interventions like the colorectal cancer screening. It usually the patients can benefit the screening if the patient has more than 10 years of survival, right? Okay, so another one would be we try to see the effectiveness of the medication and the side effect profile of the medications. If the medication has good effectiveness and low side effects, such as the use of the ACEI, beta blocker for heart failure, we would want to keep it, all right? But then if, to the other hand, if the patient taking some medication has poor effectiveness, but then with high risk or the complication side effect, we would want to omit it, all right, or avoid it. The same apply to some medication list. If you have the patient has already has some adverse reaction and polypharmacy, you would want to judge whether this medication is applicable or useful to the patients. If the patient has the life expectancy and also the versus the time to benefit ratio, right? It is mainly for preventive drugs, the calcium bisphosphonate, statin. If this is for primary cardiovascular prevention, right? So you would want to judge if the patient has the life expectancy longer than the TTB. We would want to generally recommend these preventive measures. So finally, last two steps would be identify the drug that you would want to discontinue, and then try to develop or deliver the plan and gradually reduce the dose or taper the dose or stop the medication with the patient and monitor the acceptancy, right? Some patients will insist to take the multivitamin. I've seen that, right? And then you have to convince the patients that this multivitamin is not necessary to you, and then it takes time. And final, because of the time, I want to skip this too, and then you can read this. It is just covered mainly repeating the previous things to summarize the things that cover for the general elderly, and for the poor health, frail elderly, what we should pay attention to the medication management. And then final two slides would be the strategy to ensure adherence. We would want to use some behavioral method strategy to enhance the patient's compliance, like make the patient understand why she or he needs to take the medications, and then engage the patient's relatives, in particular the spouse or partners, in order to supervise the medication use And this is very important. And then every time, if the patient is English literature illiterate, and then you will want to try to give the patient some Chinese written instruction in order to enhance the medication use. And then there are some methods like using the apps, mobile apps, some practical tools such as the pill box, the inhaler device, which is suitable to the patient's coordination, eye-hand coordinations. These are the very important tools to enhance the medication's compliance or the adherence to the patients. Okay, this is all of my things that we want to cover in this lecture. Thank you. Because of time, Professor Kwok has come, so I would want to end at here. Thank you.
Okay, good morning, everybody. So the second talk this morning is about dementia and delirium. Okay. So let's talk about dementia first. Well, when we talk about the aging population and the worry about the burden of aging population, we should consider the major cause of dependency with aging. And this is the list of common medical conditions and disabling conditions in old age. And out of these, dementia appear to account for the most of a major cause of dependency in old age. So the amount of disability is even more than stroke or depression, etc. So dementia is a significant problem related to aging. Well, this is the most representative study about the prevalence of dementia in Hong Kong. It was done over 10 years ago now. Professor Linda Lam in Department of Psychiatry, she did a prevalence study of 5,000 older people living at home. It was a random sample according to census. And her team examined each one of them for evidence of dementia. I note that they excluded people in OH home. So in this sample, they found that the prevalence of dementia is clearly age-related. So below the age of 70 is actually a rather unusual, is an unusual diagnosis. But after the age of 70, the prevalence increased almost exponentially. So when you look at people above the age of 85 or more, over a third had dementia. Another point to make about this slide is the gender difference. If you look at this age group, there is some very clear gender difference in favor of the male sex. Older women seem to have much higher risk than older men in dementia. Okay, but then whereas the difference seems to be less marked, slightly less marked with younger age. So could you postulate the reason why there is such a big gender difference? Could you try to have a guess as to why there is such a gender difference? This is an important point because clinically, you'll find that a lot of dementia patients are female. Well, one of you suggested longer life expectancy. This factor is not important because the prevalence rate is age adjusted. So everybody was in the same age group. So it's not the longevity. In fact, when you look at people above 85, there was no gender difference. Only in this, in the age group of 70 to 85. Difference in health-seeking behavior? No, because it was a research study. In fact, only 1 out of 10 people found to have dementia in this study were ever diagnosed. They were detected by the psychiatry team in this research study. So it's not health-seeking behavior. Most of them were not diagnosed, and most of them were in early phase of dementia. What's the major difference between older female and older men around this age group? Well, the answer is education. In this generation, the older generation, older women had very little chance of education. Hong Kong and China was poor, a century ago or a few decades ago. So when condition was poor, there was a prejudice against women. And so the girls did not have chance of education. And low education is a risk factor for dementia. At least they will present earlier than people with higher education. So people like Go Kun, our ex-vice chancellor, he also had Alzheimer's disease in the 70s, despite a lot of education and high IQ. So this shows that that there are lots of factors related to dementia, and genetics plays a big part. But intelligence does protect us, in terms of the onset, the timing of onset. If one has a better brain to start off with, then more brain reserve, so to speak. I wouldn't say better or worse, but better, more brain reserve, then one can expect to develop dementia later in life. So that's why in this, so the peak in this age group, there was the chance of dementia is already very significant. And if you have low education, then you're more likely to develop dementia. Whereas in the extreme age of 85 or more, then even though you have high education, it becomes not a significant factor because it is getting, the time has gone sort of passed, and so even people with high education could develop dementia, and that's why the gender difference disappeared in the extreme old age. Dementia is not a disease. Dementia is a syndrome. It's just a collection of symptoms and signs. It does not really tell us anything about the underlying pathology. Actually, for many years, people have believed that dementia is part of aging. And only in recent years, when we look into the problem in more detail, that we discover that it can be caused by a number of diseases. And out of these diseases, Alzheimer's disease seems to be the most important. It was first described by Dr. Alzheimer's over 150 years ago. He had a patient. He was a neurologist. He had a female patient in her early 50s developing dementia symptoms, and she died a few years later. When she died, Dr. Alzheimer's examined her brain and found that in the brain there were lots of plaques. Okay, and now we know that the plaque is caused by beta amyloid protein, which is the abnormal protein, extracellular protein, and this beta amyloid is neurotoxic. And the other feature is neurofibrillary tangles. And when we look at the biochemistry, and well, this structure, what does it look like? Does it remind you of any particular structure of neurons? Which part of neurons is this? Is it because of the different occupation before? Yeah, one student asked me whether occupation matters. Yes, this is a good question. Occupation, having work, is protective of dementia. So if somebody has never been employed, then the chance of dementia is greater because with our work, our brain gets stimulated, especially when one is engaged in work that relates to the brain function. So if it is related to just labor, just heavy labor, then it might not be that protective. But if it is involves brain power, like teaching or being a doctor, then it is protective. Yeah. So ask questions apart from education. Ask questions about the job. Okay. Okay. Let's come back to the pathology. So what does this look like? As a hint, it is part of a neuron. Which part of the neuron does it look like? The tangles. What are the two main parts, components of a neuron? Well, three main parts. You have the cell body. Apart from the cell body, you have dendrites, which receive messages from other neurons. And you have a long axon, which transmit the message to other neurons. So this is the axon part, axonal part of neurons. Basically, what happens is the axon, there's something happening in this axon, which impairs the transmission of message from the cell body to the nerve endings. Okay, so basically, this neuron is non-functional because the axon is all clotted up. And we now know that it is hyperphosphorylated tau protein. Tau protein is important in the maintenance of the neurotubules within the axon. So when the tau protein becomes denatured by hyperphosphorylation, then the whole axon does not work. So it's a sign of cell death. So actually, tangles is the end stage feature of a whole range of neurodegenerative conditions. It is not unique to Alzheimer's disease. If you have other neurodegenerative conditions like Lewy body dementia, frontal body dementia, you have tangles as well. So basically, what happens is that the Alzheimer's brain accumulates beta amyloid protein, which is neurotoxic, and somehow this leads to degeneration and neurodegeneration and axonal cell death. But exactly how beta amyloid translate into tangles is still not clear. But the end result is that the brain becomes atrophied, cerebral atrophy, particularly affecting the hippocampus. And hippocampus is important for short-term memory. And that's why short-term memory loss is an early feature of Alzheimer's disease. So these are the risk factors of Alzheimer's disease according to epidemiological studies. Age, obviously, I've shown you that. Female sex, there's a female predominance, but not as much as this figure suggests. This figure sort of is affected by the low education of our older population. In Western population, there is still a female predominance, but not as much as this. Family history is important, especially if you have a family member who have early onset Alzheimer's disease. The earlier the onset of Alzheimer's, the more genetic the cause. So if you have a family member who develops Alzheimer's disease at the age of 70 or earlier, then the children of these people will have 3 to 4 times the risk of Alzheimer's disease because they may get the bad genes. There are over 100 Alzheimer's genes that we recognize, but the effect size of these genes are usually very small. But the most important genetic marker we've found is ApoE4. So if you have 2 copies of ApoE4, then your chance of Alzheimer's disease is 10 times the normal population. And if you have 1, then lower risk. But fortunately, we Chinese people, we do not have, the prevalence of ApoE4 is less than 5% in Chinese population. So we are relatively at lower risk of Alzheimer's disease. Down syndrome, people with Down syndrome, they are born with 1 extra chromosome, and that extra chromosome leads to more beta amyloid production, And that's why they develop Alzheimer's disease in their 40s and 50s. People with a whole range of psychiatric conditions, their brain is not normal. And so when these people become old, they are more likely to develop Alzheimer's disease. Repeated head trauma or significant head trauma resulting in loss of consciousness will increase your risk of Alzheimer's disease long term. So that means in your 20s, early 20s, if you are hit by a car and go unconscious, then in your 70s, you're more likely to develop Alzheimer's disease. Then diabetes is associated with cerebrovascular disease and vascular dementia, but also increase your risk of Alzheimer's disease. The extent is about double the usual risk of Alzheimer's disease. So given that diabetes is so common, and also that diabetes can also cause vascular dementia, this suggests that older people with diabetes are at very high risk of cognitive impairment or dementia. I've mentioned about low education. So apart from Alzheimer's disease accounts for about 60% of dementia in old age and contributes to about another 20%. But another major cause of dementia in old age is cerebrovascular disease, vascular dementia. Well, when we say cerebrovascular disease causing dementia, we must make a distinction between small vessel disease, as you can see here, from stenosis of major cerebral arteries. So if you have stenosis of cerebral arteries, then you're more likely to get stroke. But with stroke, it does not necessarily give you dementia. It depends on where the strokes are. But the most clear association between cerebrovascular disease and dementia is actually small vessel disease. So this is small vessel disease usually happens around the ventricles. We call this periventricular ischemia. And this is where the white matter lies. White matter is in charge of communication among neurons. So if you have ischemia of the white matters, that means that the neurotransmission among neurons are slowed down or impaired. And also, you are likely to get lacunar infarcts, okay? So these people, they typically present with mild stroke, because they have lacunar infarcts. So paradoxically, people with mild stroke are more likely to develop dementia than people who have developed a major hemiplegic stroke. Because major hemiplegic stroke is usually caused by stenosis of cerebral arteries, like middle cerebral artery will give you a devastating hemiplegic stroke. It might give you dysphasia, but it does not give you dementia. People don't get worse with time. The cognitive function does not get worse with time. But then if you have a minor hemiparesis from lacunar infarct, from small vessel disease, paradoxically, these people are more likely than the hemiplegic patient who from middle cerebral artery stenosis to develop dementia after a few years. This is an important study. It was done a few decades ago. A few hundred American nuns living in the same monasteries had cognitive assessment every year. The important point is that these nuns donated their brains when they died. The idea is to look at the associated factors of Alzheimer's disease. A major finding was that if you have Alzheimer's changes in the brain, okay, but no cerebrovascular disease, then your MMSE dropped from 30 to 15. So this is a typical result of Alzheimer's disease. But if you have Alzheimer's disease as well as brain infarct, that means cerebrovascular disease, then your MMSE dropped to 3. So that suggests to us that Alzheimer's disease and cerebrovascular disease have additive adverse effects on brain function, on cognitive function. So they work together. Whereas if you do not have Alzheimer's disease, but you have cerebrovascular disease, actually it does not affect your MMSE that much, okay? Only very, very slightly. So these are the normal control, okay? So this is an important point that no matter whether somebody has Alzheimer's disease or not, it is important to prevent cerebrovascular disease. So vascular management of diabetes and hypertension, hyperlipidemia remains very important in dementia prevention. Okay, right. Next, I'll talk about the clinical diagnosis of dementia. There are a number of other causes of dementia, like Lewy body dementia, frontotemporal dementia, and HIV dementia, syphilitic dementia. But I'm not going to go through that with this lecture because of the interest of time. But those are the smaller prints, and they do not happen that often. But let's come to the clinical diagnosis of dementia. The problem with dementia diagnosis is that it is a clinical diagnosis. There are no diagnostic tests. It is all down to our clinical impression. So that's why this diagnosis is commonly missed, and it varies from doctor to doctor because there's no objective data for calibration. So basically, what we are looking for are symptoms of dementia, which is impaired episodic memory, impaired orientation. Episodic memory, that is things that has just happened. For example, what you have eaten for breakfast this morning, okay? We remember these things without any conscious thought, but for people with dementia, they cannot remember, no matter how hard they think. The other problem is orientation. The first component orientation that's affected is orientation to place. So when they go out, they cannot find their way around and get lost. So getting lost is an important history. The other major deciding factor as to whether somebody's dementia is whether they can look after themselves, ADL function. So whether they can live independently. So if somebody is living with a spouse who is very helpful, then the dementia symptom may not be apparent so early on because the spouse has done things for them and keep reminding them of things. And that's why some old people appear to be all right, but in fact, they are not all right. They cannot function independently. And another associated factor, which is helpful to diagnosis and also very distressing to family caregivers, is mood swing. They're more likely to be temperamental. because Alzheimer's disease affects the temporal lobe, which is in charge of emotion, so that they are more emotional, and because the frontal lobe may also be affected, the emotion cannot be controlled by the frontal lobe, and that's why they appear to be moody and lose the temper quite easily. The most common symptom is anxiety. Admittedly, if you have dementia, you have a sense of failure in your normal life, and it's a progressive decline. So not surprisingly, a lot of people feel very insecure, so they feel anxious and paranoid. And the symptom is usually comes from the caregivers. Most people with dementia do not complain about dementia. Firstly, is denial. Okay, when you feel that there's something serious going on with you, you try to put it off. You deny it. The other reason why people with dementia do not complain is that they lose their insight. They don't know that they have a problem. Okay, and that's why most of the people with dementia, they are brought to see the doctor by the family caregivers who are distressed by the cognitive decline of the family members, especially their mood, their temper, that they cannot tolerate. And that's why they bring the elders to you. So that's the reason why dementia tends to be diagnosed late, because you have to wait because the patients do not present, you have to wait until the family caregivers cannot tolerate the dementia, then they might bring the person to see a doctor. And also you have to convince the family caregivers that something can be offered. If as a medical profession, we cannot convince the general public that there are effective drugs or other interventions that can help with dementia, then the family caregivers will not come forward. And that's why we've been doing a lot of public educations to increase the public awareness of the symptoms of dementia, and also emphasize the room for improvement when in the management of dementia. There are drugs to alleviate the symptoms, and also there are drugs effective to control the mood swing and the temper, and also cognitive training, physical training can also slow down the progression of dementia. So by emphasizing the positive side of management, then the families will start to bring the elders for medical diagnosis and attention. And then the third part is that we have to do some cognitive tests to have some objective evidence that there is cognitive impairment. So these are the symptoms of dementia: forgetfulness, getting lost. Loss of interest is an important symptom, actually. And another term for this is apathy. So nothing matters to them anymore, and they don't do things. They just sit around doing nothing because they are not interested. Somebody who's normally interested in mahjong or family gatherings, that they are not doing this anymore because they are not interested. Okay. And another point I want to highlight is the walking. People with dementia have problem with walking. Alzheimer's disease can affect the gait by, the gait becomes uneven. When we walk, the step is usually automatic and and the step length is usually very even, so that would increase our stability. With Alzheimer's disease, the step length becomes uneven and random, so that put them at risk of falls, especially for those who habitually walk quite fast. So the faster you walk, and if your gait is not steady, then the more likely that you fall. And for vascular dementia, they walk more slowly. The steps become very small step gait. And so that would also increase the risk of falling. They would tend to fall forward. So overall, people with dementia have much higher risk of falling, at least 4 to 5 times more than the general older population. So they are very at high risk of hip fracture. So this shows you the distinction between the clinical features between Alzheimer's disease and vascular dementia. Alzheimer's disease is a slow progressive history. There might be a family history because there's at least 50% genetic predisposition. They lose the insight quite early on, and they get disorientated on going out, but they do not have any neurological sign. But with vascular dementia, the decline is stepwise. So suddenly they get worse, and sometimes it's so sudden that people suspect that they have a small stroke, but it may not necessarily be the case on MRI scan. Because of the small steps and lack of facial expression, then they look Parkinsonian, but they do not have the tremor. They don't usually have tremor, but they may have rigidity, small steps, and Parkinsonian faces. And we call this, another term is vascular Parkinsonism. The reflexes may be brisk. On the CT or MRI scan, you see paraventricular ischemia, and they typically have vascular risk factors. Another risk factor that is not increasingly recognized is obstructive sleep apnea, and it can also lead to small vessel disease. And the memory is usually preserved in the early phase, but they have problem of ADL. Okay, they do not, so they cannot look after themselves properly. Although they have got the sensory and the motor function, but they cannot do things as well. They become clumsy. So we call this executive dysfunction. So vascular dementia patients look quite normal. They preserve the personality, the memory is all right, but they do not look after themselves well, and they have a loss of interest as well. So they appear to be lazy, and if they are diabetic patients, then the diabetic control may go haywire because they are not interested in taking medication or to have any lifestyle modifications or restrictions. Lewy body dementia, just very briefly here, some interesting features is that they have visual hallucination, and they have REM sleep disorder. Talking in their sleep, falling out of bed because they move with their dreams, and they have paranoia and Parkinsonian features, and they respond well to cholinesterase inhibitor as in people with Alzheimer's disease. And if you give them phenothiazines, they would become markedly Parkinsonian. And this accounts for 10% of all dementias in old age. So I'm not going to go through, except to mention that frontotemporal dementia is something to consider in young people with dementia, middle age. The onset is in the early 50s, late 40s. Okay, let's come back to the cognitive tests for screening. Well, I recommend, as a screening test, I recommend mini Kwok test because it does not take long. But for more definitive, assessment, we used to use MMSE, but not anymore because there's the problem of license. So one is expected to pay a license fee for the use of MMSC. So we now move on to MOCA test, Montreal Cognitive Assessment, and we don't have to pay license fee for that. And these two are the commonly used tests which covers major cognitive domains. So these are cognitive function has many domains, and memory is only one of them. So it covers a whole range of assessment of the whole range of cognitive domains. MOCA is actually quite sensitive to early changes, whereas MMSC is only affected in the relatively later phase of dementia. The problem with cognitive tests is that it's affected by education level, so it's not that reliable for people who are illiterate because it involves writing using the pen and also some linguistic ability. So it's a challenge to do cognitive tests in people who have low education. And also people who are depressed or anxious, they might perform badly. People who are very sick, they might not be able to pay attention and cooperate with the testing. So the cutoff values are for references only. They are not diagnostic. It's not the same as a fasting glucose to diagnose the diabetes. Cognitive test is for reference only. So I recommend the use of mini Kwok test. What it is that you give them 3 unrelated words to remember and ask them to repeat the words and let them know that they are supposed to memorize them. And you will ask them to recall them at a few minutes later. And then you ask them to draw a clock, draw a clock face and indicate a time. Usually we use 10 past 11, okay? And then after they've drawn the clock, you ask them to recall the 3 words. If they can recall all 3 words, then they're all right. They pass the test. If they cannot remember even one, then they have failed the test. They have dementia. If they can recall 1 or 2, then you look at the clock. So if the clock looks like this, then the person has failed. So this is somebody with a low education, 1 or 2 years, and the diagnosis is actually MCI and paranoia. Okay, and that person cannot draw the clock properly. Okay, and for the MOCA test, we have some local reference in terms of percentile related sort of in comparison with normal population of the same age, sex, age and education level. So if it is less than the 2nd percentile, that means you are worse than 98% of the general population, then you definitely have dementia. If it is between 2 and 16, then is MCI. And if it's more than 16, then probably normal. So, but then it is for reference only. Okay, it's not 100% accurate. Okay. The whole test takes about 20 minutes to complete. In terms of investigations, again, there are no diagnostic tests. We do some basic biochemistry to look for renal failure, liver dysfunction, check the fasting glucose for diabetes because this is important cause of our dementia. We check for vitamin B12 and folate level. I missed out folate. So if you are deficient in these two important vitamins for brain, then a replacement may help. We normally do a brain scan. CT scan will help to exclude other causes of dementia. For example, brain tumor, stroke, normal pressure, hydrocephalus, but it does not give you accurate information about cerebral atrophy or small vessel disease. And that's why MRI is better. MRI now will give you, volumetric MRI will give you indication of atrophy of specific brain region. For example, hippocampal atrophy, and it can give you an accurate estimation of the extent of small vessel disease. The definitive test, a more accurate test, is the PET scan test. There are two components. One is glucose, because if you have brain degeneration, the parts of the brain affected by brain degeneration will not utilize glucose properly. So you will have areas of the brain which does not metabolize glucose. Okay, so if you have Alzheimer's disease, it will affect, you expect a hypometabolism of glucose in the temporal lobe, okay, and to some extent frontal lobe. But a more definitive test is beta amyloid PET scan. I'll come to that. So this is a major advance in the last decade or so. For the first time, we're able to diagnose Alzheimer's disease without waiting for postmortem. Basically, we inject a radioactive label for beta amyloid. After the intravenous injection, the tracer will get to the brain and stick to beta amyloid accumulation in the brain, and then the PET scan will pick up the abnormal radioactivity and show up as red spots. Whereas in this patient with no Alzheimer's disease, the brain is clear. Unfortunately, this test costs about $20,000. So it's not something that we use that often. And now there's another PET scan for tau, abnormal tau. So apart from, in addition to beta amyloid accumulation, we can also tell if some parts of the brain have been affected by neurofibrillary tangles, okay? So we have very good PET scan test technology to diagnose Alzheimer's disease. But unfortunately, because it is something new, it costs a lot of money to have the diagnosis. But at the moment, I think, with MRI, we have a pretty good idea about the state of affairs in the brain. This patient has got 3 causes of dementia. Firstly, this is small vessel disease, okay? And secondly, abnormality is here. Do you know what that is? Anyone? What is the abnormality? that I'm pointing out. What's this structure? This is a coronal view of the brain, cut from the top to bottom. So what's this structure? Anyone? No, well, this is hippocampus. Hippocampus, okay? What it is showing is hippocampus atrophy, okay? Hippocampus is the most active part of the brain. It regenerates neurons very slowly, but it's the only place in the brain that give you new neurons. And this is the area that is first affected by Alzheimer's disease, okay? So it indicates that the person has Alzheimer's disease. And also you can see the temporal lobe is relatively atrophied. And then there's a third here, is the basal ganglia. There is an infarct in the basal ganglia. So this patient has got three causes of dementia: small vessel disease, Alzheimer's disease, and basal ganglia infarct, which can also cause confusion. So the situation of dementia, the causes of dementia in one particular patient could be multifactorial. So may not be just one disease. It might be a combination of different diseases. And that's why there's a lot of variation in the way the patients present, and also variation in how quickly they decline. When we talk about dementia, there are the whole process. Dementia is very long. Well, this diagram suggests it's 9 years, but I suggest it is longer than that. So 10 years or more. And so at different stages, there are different, the features are different. And there are lots of things we can do to slow the progression. Physical activity, okay, is very important, and it will help to preserve the health, general health, and the general health will preserve brain function. But it is not easy to do because dementia patients have apathy. They do not have interest in anything. So to persuade somebody who is apathetic to do exercise is very challenging. And also, when they do physical exercise, they might fall. So they need to do physical exercise under supervision. So that involves a lot of care and attention. Nutrition is important. Make sure they eat enough, especially fruit and vegetables. Maintain the social activities to keep the mind active. Supervision and company to keep them safe and happy. Think about fracture risk, treat osteoporosis, and make sure they don't get lost. If they have visual impairment, extract the cataracts, apply hearing aid, and give them a good sleeping environment so that they sleep easier because they have problem of insomnia. Drug compliance needs to be monitored and supervised. Polypharmacy should be avoided because, if they do not use the drugs properly or doctors prescribe too many drugs and causing side effects, that might aggravate the situation. Avoid the drugs that have brain side effects. For example, anticholinergics like antihistamines, which are commonly prescribed for flu-like symptoms. L-dopa will make people anxious and confused. Propranolol beta blocker might slow things down in the brain. So we have to be careful in the use of drugs in people with dementia. Drug therapy for Alzheimer's disease, there are two main categories. One is cholinesterase inhibitor. It works by preserving the acetylcholine level in the one of the important neurotransmitter for memory in the synapses. For people who are for the subjects who are taking placebo, the cognitive function declines like this over 1 year. But then if you take the cholinesterase inhibitor, then you decline more slowly. So you might say that this drug is not useful because you still have decline, because it is not disease modifying. But you can also say that it is significantly effective, because if you compare with the placebo group, there's a clear difference at 1 year. And if you extrapolate this over a few years, then the benefit can be more noticeable. So I would say that this drug is mildly effective. I wouldn't say it is not effective, it's mildly effective, and certainly effective in delaying the decline. But it has side effects. Because the GI system relies on acetylcholine also for its neurotransmission. So if you increase the acetylcholine level in the GI tract, it becomes overactive and causes GI upset, and is very common. But the good thing about this is that it is reversible. As long as you stop the drug, then these symptoms will go away. But it also causes bradycardia sometimes and increase the risk of syncope. So for people with cardiovascular, particularly cardiac arrhythmia, people with history of syncope, then it should not be used or used with caution. Because of GI side effect, the drug companies have sort of a good idea of giving the drug by a skin patch. The advantage of a skin patch is that the absorption is slower and more even. So because at any one time, the blood level of acetylcholinesterase inhibitor is lower, and that's why the GI side effect is lower. And it's also maybe more acceptable to some patients because it does not involve taking medication. Another class of drug is memantine. It is a competitive antagonist of glutamate. And glutamate is another major neurotransmitter in the brain. It is effective both for Alzheimer's disease and vascular dementia. The advantage of memantine, it is well tolerated generally, but it appears to help only in moderate to severe stage of Alzheimer's disease. It's not effective in early stage dementia. Yeah. So in Alzheimer's disease, people get abnormal reaction to glutamate. So the normal response should be like this, but then if you have Alzheimer's disease, then it becomes exaggerated and cause neurodegeneration. But then if you give them memantine, it calms things down a bit. The effect size of memantine is small for ADL, cognitive function, and behavioral problems, but it is significant. But it is important to note that memantine helps with behavioral problems, which is a major concern for family caregivers. Although it is not that effective, but it is better than nothing. And that's why we typically will add memantine in moderate stage dementia. So in early dementia, early AD, we start cholinesterase inhibitor, but in the moderate phase, especially when the BPSD appear, then we add in memantine. Neuroleptic drugs are commonly prescribed for behavioral problems, which happen to over 90% of people with dementia. if, well, neuroleptic drugs, they are effective in slowing down reducing psychotic symptoms, reducing agitation and aggression up to about 6 months. But they have a common problem of causing Parkinsonian side effects and oversedation and increasing the risk of falls. They're also at risk because of Parkinsonian dysphagia. They're also at risk of pneumonia. So overall, there's an increased risk of mortality with neuroleptic drugs. And that's why I try to use it as sparingly as possible, not to use it unless it's really necessary. And some behavioral problems, like wandering, late night reversal, they do not respond to neuroleptic drugs. There are other alternatives like SSRI. They're effective in reducing anxiety, which may be the basis of some behavioral problems. Trazodone is commonly used. It is antidepressant, but at the same time, it may reduce some agitation. And it's also, it promotes sleep. It's very sedating. So by giving it at bedtime, it helps with the sleep in people with dementia. So it's a useful drug. Memantine is useful for behavioral problems, but the effect is small. Sodium valproate will reduce the amount of temper, the aggressive response to temper, but it has got a lot of drug interactions. But there's a lot of, apart from drug management, there are lots of things that we can do to reduce caregiver stress. As I mentioned, dementia is a problem for the family, okay? Not so well, to a less extent, for the patient with dementia, but it's more a problem for people with the family who look after them. They are under a lot of stress, psychological stress. So there are lots of psychosocial interventions we can do to reduce caregiver stress. The most useful is dementia daycare. And that's why we started Jockey Club Center for Positive Aging over 20 years ago. So this is basically a dementia daycare center. Every day, people with dementia come to our center for group exercise, group activities to promote social stimulation, cognitive training. In addition, we give support to the caregivers and also train the caregivers in training in the caregiving. So this is a multidisciplinary approach. And once the caregivers are empowered and get less stress, they do a better job in caring. And so to the people with dementia, they get better care and they are happier and decline less quickly. So in summary, dementia is a clinical diagnosis. We have to look out for it because the patients do not complain about it. So don't wait for the families to be worn out before we go for this diagnosis. Even in a normal day practice in dealing with older people, look out for cognitive impairment and dementia. And there are drugs available to slow the decline in cognitive function in ADL and reduce behavioral problems. But we have to be careful about the use of drugs because of the problem of polypharmacy and side effects. Caregiver support is very important to the family. So it's part and parcel of the management of dementia. So don't forget about it. It's not just drug management, but also psychosocial interventions. And doctors play an important role in early detection and drug management. And also the GPs may more likely to deal with intercurrent illness and refer them to appropriate community service providers to give psychosocial support to the family. Okay, so we are running out of time, but I would like to spend another 10 minutes to cover another important topic of delirium, which is related to dementia. Before I do that, do you have any questions? One student asked, what is the indication of using PET scan in Alzheimer's disease? This is a good question. When somebody presents with dementia and the diagnosis is quite clear, then it is not cost effective to do PET scan because it's expensive. I think a more useful way to use the PET scan is actually to exclude Alzheimer's disease. So, for example, if you have a young patient presenting with dementia, you are not really sure whether it is frontotemporal dementia or Alzheimer's disease, then do a PET scan for AD. And if it is not AD, then it is very likely to be frontotemporal dementia. Then you do not start the patient on cholinesterase inhibitor. Okay, you avoid the trouble of prescribing drugs they do not need, and may even aggravate the symptoms, aggravate the behavioral problems in frontotemporal dementia. Another use of PET scan, amyloid PET, is in the situation of MCI. When somebody has the early phase of cognitive impairment, MCI, that is the prodromal stage of dementia, they have memory problem, but they can look after themselves in general, and they do reasonably well on the cognitive tests. So these people, they are dementia. They do not have dementia, but they do have evidence of maybe Alzheimer's disease, and it is probably important to know, for some people, to know whether they are likely to progress to dementia. And one of the determinant of this is the presence of Alzheimer's disease, because MCI is a very general thing, and it can be caused by a lot of different causes for MCI. For example, just not sleeping well with sleep apnea might give you MCI. So for people who are eager to know whether they are likely to progress to dementia, then do amyloid PET. And if it shows that they have beta amyloid in the brain, then it is actually bad news. That means they're more likely to progress into dementia. And now another issue is that there is now effective antibodies. Actually, the US FDA has controversially approved a drug which is an antibody, a man-made antibody against beta amyloid. So in the future, the vision is that in the future that we scan people with cognitive impairment for beta amyloid and confirm the diagnosis of Alzheimer's disease. And in these people, then giving them the amyloid antibody may be an effective preventive treatment, preventing them from developing Alzheimer's disease. This is something for the future. Okay. Okay, any other questions? Okay, so if not, then I'll just jump very quickly, go through delirium. This is acute confusion is very common when frail older people become acutely ill for whatever reason. And often these people have pre-existing cognitive impairment. So there's something wrong with the brain. Okay, for most of us, if you have a pneumonia, we don't get confused. But for the frail older people who have brain disease of some sort, when they become ill with pneumonia, then they get confused. If they get a myocardial infarct, they get confused. They get heart failure, they get confused. Okay? And the important point about this, once you develop delirium, immediately your chance of survival is reduced. It is associated with deconditioning and prolonged hospital stay. There are two main types. One is two-thirds is the more common type, which is more noticeable, that is hyperactive. These people are very anxious and they shout and they jump about, they try to get out of bed. Okay, this is the confused patients that we are asked to deal with, and the nurses dread them. The other one-third is hypoactive, which is under-recognized. These people become very sleepy, unarousable, not eating very much, apathetic, and so commonly we just thought that they are just very sick, but it is may just be delirium, hypoactive type, and is because of this, because they don't make any trouble, they get missed. It is said to be reversible. If you can reverse you can treat the cause, the precipitating cause like pneumonia, then the delirium might improve, maybe reversible. But then the important point about this is that after an episode of delirium, people get some degree of cognitive impairment. So it does leave a mark in the brain. The longer the duration of the delirium, the more residual cognitive deficit. How to look for confusion? There is the most commonly used clinical method is this. We look for acute onset and fluctuating cause. That means they may appear to be all right in the morning, but then get confused at night or the evening. And then it happens all of a sudden, sort of quite acutely. Another feature we can recognize clinically is inattention, flight of ideas. They cannot concentrate on the task. So, and the thinking is disorganized. So you ask them a question, they give you inappropriate answers. It might be appropriate in the first few words, but then they get distracted and think of something else. So we call this incoherence. They don't give you coherent answers to any questions, and they cannot pay attention. Another useful clinical feature is conscious level. Sometimes they are hyperactive, they are very sleepy, and sometimes they are hyper alert. They are very alert. What is hyper alert? They are conscious of any slight noise of movement and misinterpret that in the paranoid fashion. So slightest noise, they may say, oh, somebody is attacking me, and try to jump. This is hyper alertness. So if you get a few features out of the 4, then you have the diagnosis of delirium. I recommend this this website that would give you the clinical method. Actually a demonstration of how to assess delirium in a hypothetical case. Write down the web page. Yeah. They also have other features like visual hallucination, seeing things, seeing their ancestors who have died a long time ago, paranoia, agitation, anxiety, and poor sleep. The hypoactive one, they get apathy. There are many precipitating causes. Okay, so anything wrong with them, even constipation, okay, fecal infection, urine retention, but more importantly, things we do to them, putting catheter in, putting drips in, applying physical restraints, all these things will precipitate delirium. An important feature to look for is pain. People usually look for infection. I don't worry about that. But people who are in pain, it may be the precipitating cause. So it's important to get history from the caregivers to find out the normal self, the normal cognitive performance, because it is the acute change that will give the diagnosis away. But it's important to have a high level of suspicion, especially if the person is old and frail. Apply the CAM criteria, as I've mentioned. You can do some simple cognitive tests like orientation, counting backwards, and short-term recall. Well, management treat the underlying cause, okay, but first thing to do is look at the drug chart. Cross out the drugs that can have CNS side effects, okay? So cross out the unsuitable drugs that affect brain function. Look out for pain, discomfort. Infection, most people would do. Metabolic, take some blood for metabolic disorder like hyponatremia, hypokalemia, dehydration. Do oximetry to look for respiratory failure. Try to remove restraints and other instrumentations that cause discomfort. Reassure the person. Call the family in to reassure the patient. Melatonin might help sleep. Okay, it is actually more useful as prevention for the frail elderly. If they take melatonin, they're less likely to develop delirium. Antipsychotics are effective for delirium. So just now I was saying that antipsychotics are very harmful, could cause Parkinsonian features, etc. But if the delirium is bad, then antipsychotic is indicated. It helps to resolve delirium more quickly, but use it in moderation. Use the smallest dose, okay, because of these side effects. Use low dose and try to stop it as soon as the delirium is resolved, okay? And use the newer neuroleptics which have less side effects. Prevention of delirium. Delirium can be prevented by good nursing care, careful use of drugs that avoid drugs that can aggravate brain function and cause agitation, avoid physical restraint, communicate general good nursing care and ensure hydration. All these things will add up to about 30 to 40% of reduction in delirium incidence. So to conclude, delirium is a serious medical condition similar to ICU care, HDU care, that might cause long-term cognitive deficit and functional decline. In some units, medical units, they have a delirium room. It's just like an HDU room for delirium because they need more attention, they need more supervision, they need better nursing care in order to shorten the duration of delirium so that they do not get the long-term cognitive deficit. The frail elderly are at risk. The trigger could be relatively minor. And good nursing care and the careful use of drugs prevent delirium. And early detection can minimize the complications. And physical restraint should be avoided. Okay, so before we finish, do you have any questions? Okay, thank you very much for your attention. Sorry to have taken more than an hour. Okay, bye-bye.